Hello, I'm Dr. Rebecca Walker from Stanford University School of Medicine, and we will be discussing today a case of shortness of breath from a woman who presents to the emergency department. So we have a 52-year-old female. She called the ambulance because she was having worsening shortness of breath and dyspnea. So the first thing that we want to do is think about emergency medicine patients, and sometimes we have to evaluate, think, and act, often all at the same time. So the first thing that we need to do in that assessment is our initial assessment, which is just how the patient looks generally. So in general, we see that she is distressed but alert. She's able to state her name, but in noticing her breathing, she's breathing very rapidly and having trouble breathing. She's tachycardic, and we note immediately that we need to get a set of vital signs. So we check her vitals, and sure enough, her heart rate is 113, her respiratory rate is 26, her blood pressure is 134/54, and her pulse oximetry is 78%. So now we think about what we just summarized into a hypoxic patient who's in distress, and she's tachycardic. So what interventions might we want to do at this point? Well, we have to act quickly, and so we consider maybe the patient needs an IV, perhaps some oxygen, and is there anything else that we need to think about? So some of the immediate interventions that we talk about in emergency medicine are listed here. So which ones should we consider for this patient, and how do we decide? So we decide first to give our patient some oxygen. And how did we decide that? Well, every patient who comes in either shock or respiratory distress needs oxygen immediately. We should supplement their oxygen status even if they have COPD, because oxygen is more important than worrying about suppressing the respiratory drive. So here our patient has a face mask. And why did we choose a face mask instead of, say, a nasal cannula or a non-rebreather? If we remember, oxygen in normal air is about 21%. So depending on how hypoxic the patient is, we want to increase the oxygen that they're receiving by either using a nasal cannula, a face mask, a non-rebreather, or positive pressure. If a patient fails to ventilate well with positive pressure, that is when they need endotracheal intubation. Another thing that we will do with our patient is positioning. So by sitting her up, we decrease the mechanical work that she has to do to breathe. We're also decreasing any pulmonary edema that might be there from pulmonary congestion, from fluid overload, or congestive heart failure. Another thing that we saw that was an immediate intervention that we decided to do is an IV and a cardiac monitor. So we place an IV in case we need to give her medications to help her breathing. As far as a monitor, we need to monitor continuously for both pulse ox and cardiac monitoring. So we see here the number 78, and it's a pretty low number, but what does that mean? How low is it? Well, we talk about pulse oximetry. That's basically what we consider a fifth vital sign for any patient with shortness of breath. Anything under 94 is abnormal, and really pulse oximetry is a measure of arterial oxygenation. It's hard to tell a low oxygen status on physical exam, and in fact, cyanosis is not present until a patient's pulse ox is down to 67%. So we're measuring a pulse ox and we're putting on a cardiac monitor. And why are we thinking about doing that? Well, 2/3 of cases of shortness of breath in the emergency department are caused by a problem with either the heart or the lung. So when we put a pulse ox on a patient, it actually detects signals from blood flow that cause a waveform like the one you see here. As you can see, there's two numbers on this pulse oximetry, the heart rate and the oxygen saturation. Pretty great information when you're talking about a patient who might have a problem with their heart or their lungs, right? So one small detail about pulse oximetry that we do need to mention is that sometimes it can be inaccurate. If the patient is moving around, they can have what we call motion artifact. that makes the pulse ox inaccurate. If they have darker skin, nail polish on their nails, or if they're outside in bright sunlight, this may be abnormal. If the hemoglobin itself is abnormal, such like a sickle cell patient or carbon monoxide poisoning, this could be carbon monoxide poisoning can make it inaccurately positive or high. The probe may be placed inaccurately or in a difficult position, and if the patient has a lot of edema or vasoconstriction, this can make the pulse ox inaccurate. If you have a patient who has a low pulse ox, you do need to keep trying to make sure that you get an accurate reading. So in our patient, we see here that our provider is checking the machine for probe placement, checking the patient for signs of anemia or edema. And in the end, if you're confused about the probe and the pulse oximetry accuracy, you should put the probe on your own finger to check, to double check. So we see here she's checking for all of those signs. And in summary, supplemental oxygen should be an immediate intervention for any patient in respiratory distress. An upright position can make breathing easier. Pulse oximetry can be surprisingly low. It is hard to detect hypoxia just on physical exam, which is why it should be monitored in every patient with shortness of breath. Patients that fail ventilation while on positive pressure need endotracheal intubation. Thank you, and this completes part 1 of Shortness of Breath series.